do we use this knowledge now to better prepare for next time? How do we do that? Now.
It's a really difficult one, isn't it? I'm not overwhelmed with the pandemic preparedness activity, and I think that's partly because I see people kind of going over the same mistakes that were happening last time. On the other hand, I have been taking screenshots and photos and sending them to my colleagues in Canada and the US. We're on a little kind of signal group around air quality, masks, multiple modes of transmission, etc. And I'm saying, look what's happening at the UK IPC conference. There's a guy out there talking about multiple routes of transmission. Someone's talking about flushing toilets. Someone's talking about air quality. There's a robot in the stalls about, ultraviolet. This is all happening. 5 years ago, that wouldn't have been happening in a conference like this. So I think, in a way, the revolution is already here, and I'm really pleased to be part of it. But we all know it's going to be hard.
Thanks for taking that one first. It's called a hospital pass. I'm a kind of glass half full person. I actually think that the public is better educated on infection transmission, and are more demanding about what they are going to expect both in the community and healthcare. And I think there'll be a huge push to make sure we learn some of those lessons. Unfortunately, most of us work in an environment where we react to the latest crisis, the latest outbreak, or the latest whatever it happens to be. But I think what we have to do is to use those opportunities to say, well, look, here's how we try and mitigate or prevent or minimize it happening the next time. And I think that communication message must continue, both amongst ourselves as healthcare workers and our colleagues, but also up the management chain, both locally and nationally.
Thank you very much. Can I invite any questions from the audience? This is a unique opportunity, people, to ask questions. This is a safe place. We talked yesterday about psychological safety and the ability to ask questions without fear. So please, if there are any questions, feel free to ask them now.
My question is, especially in light of what's happening, in the world and the cost of things, what research is showing and what we've learned through COVID, because it was quite a difficult period, do you think that they will take any notice of this, or do you think costs will get in the way? Or we've got to save money, save money, save money. So we know as IP nurses, there was a lot of learning for IP nurses, what we see as best practice and what they're doing now. For me, one of the biggest things for pathogens and respiratory viruses is that we seem to have trust now going to get the flow through these fit to sit treat areas where you're crowding people in for, from 24 to 30 to 72 hours. They're already incubating, breathing in with each other. You can have all these wonderful things in your isolation rooms, your single rooms, whatever you want to call them, and all these other things in the bays, but they're already incubating it, already growing it, and then they're coming out with it, So if it's one person come in and they're sat in a small environment with no ventilation, not even windows, they all come out, they've probably all 20 of them got it, And I just think saving money might be a bigger influence than what we should be learning through that, what happened in the pandemic.
Maybe if I can answer that first, if I may. I think we need to refocus the discussion on value for money and saving money. One of the problems we all have in preventing something is it's much more difficult to convince somebody to give you resources to prevent something than to deal with a problem when you have a problem, or to give money for something that will, say, reduce a surgeon doing 20% more procedures in a particular point in time. But I think, there's lots of good evidence out there now about the costs of infections both in healthcare but also in society. Remember, when somebody is in a hospital because of an infection, they're not in the community, they're maybe on disability payment, they're not out contributing to VAT returns, maybe they're not paying income tax. There's a huge societal cost from infection, and there's a value in infection prevention, apart from, obviously, as humanitarian healthcare workers, we believe in reducing pain, preventing death and so on. But we have to continue that dialogue. This is value for money. It means we get more patients through more effectively, more safely, better quality of care. And we can, and I think we should, use more patients in the public.
Yeah, I agree. And thank you so much for that question. It's just brilliant to have, you know, frontline clinicians coming out and saying, this is what's happening. I do quite a lot of work around organisational change and implementation of innovation and that kind of thing. And I've also, you know, I worked myself in the NHS for, you know, 40 odd years. I know what you're talking about. Now, one of the things I've learned is that you've got to measure something, and you've got to get the kind of data that will allow feedback to people within the time frame that allows them to act. And I'll tell you an interesting story around, it's not around infection control, but I think it'll illustrate something. So I used to work with a woman called Sarah Fraser, and she did a bit of consultancy in the US. And they had problems with bed occupancy. We all know about bed occupancy. If the bed occupancy goes above about 97%, it's terrible. You know, you can't admit anyone. The front door basically is closed. And so the idea is we keep bed occupancy a little bit below whatever the level is. The problem is that you might measure bed occupancy, but the people who are responsible for discharging the patients don't know about today's bed occupancy until 3 weeks' time when they see the report. That's no good. So Sarah Fraser was working with a hospital, and she realised that all the consultants came in and parked in a car park, which was just a consultant's car park, nice, hey? And there was a little screen which would have said car park empty or car park full, or however many car park spaces were available. But it somehow wasn't being used. And she realised that as the consultants arrived in the morning, they could actually change what was on that screen. And so they changed it to bed occupancy right now, 97% or 94%. And so as the consultants were arriving to do their work, they picked up that metric, and then they would go in with that metric at the top of their mind. Now I'm telling you that story. You go back to this example of, you know, these patients are sort of sitting there festering with stale air and all that kind of thing. If you can find a way of measuring one thing and feeding that metric to not just the frontline staff, but the people who make the rules on a timely basis, then I think you've got the beginnings of something that could lead to change. And I'm not sure it would cost a huge amount, because once you start solving the problem, you might end up with fewer patients in there because, you know, whatever. How about that?
Yeah, thank you. That's fascinating. And just on the side of that, because obviously of its importance, I think there's also the lived experience of patients and that patient-person carer voice, which is very, very powerful, actually. So just to consider that.
Thanks very much for the lecture. It is just, it's a very good thing to sit down and listen to this kind of advanced lectures. But then the elephant is still within the room. Because you go as an infection control nurse specialist or infection control personnel, you carry out your audit, and then you measure the metrics, and then you give the implication, and then you add the recommendation. But then what you have, then you send it to the authority. But then it could be a hospital or a primary care that has been built over God knows how many centuries ago. Then what you get, back is, oh, we don't have the money to do that. You know yourself. That is just too much. So what do you do?
I hear you. I hear you. I've been there. It is not for me as an Oxford academic to come and try and answer that, but I do hear you.
Yeah, I think sometimes we don't communicate. I'm not saying in your situation, but I know I've made the mistake that we don't communicate in a language that our colleagues understand. We don't relate it to their practice. And I think sometimes we get caught in the detail of our data, for example, rather than, simple messages, the bottom line, and what it will mean if, for example, you take on board what I'm suggesting you do vis-a-vis, down the road. Make it a win-win situation for whom you're talking to, I think. So that, okay, you want to see an improvement, less patients infected. But this is not just a win because patients don't get infection, but it also means, for example, you can do more procedures, or you can admit more patients, or you can maybe use the money that might be spent in that particular unit on other issues or development.
Can I say one more thing? So I know we're coming up to tea time. One of the things across any aspect of healthcare, or indeed any other organisational field, that really helps innovation and change is devolving decision-making to frontline groups. If you have to go up several committees and several levels in the hierarchy, by the time it's got to the chairman of the board, it's the whole thing is lost. If frontline teams can innovate and change and arrange their own environment. I'll tell you a great example of this. A few years ago, I was one of the doctors that was working at the London Olympics, and we arrived 2 weeks before the athletes, and we'd got this brand new building, which is now a GP practice in Newham, but they said this is going to be the medical building. There's going to be a little A&E department, there's going to be a GP practice, there's going to be an X-ray department, physio, pathology. Build it. And there were about 40 or 50 of us, and there was all these flat packs and cardboard boxes and IKEA sofas and for the staff room. We built it, we put it all together, and nobody was in charge. And we said, well, this is what we need. And we definitely, and the pathologist said, what we need is this. And the X-ray people said, we must make sure of this. And you know what? It worked really, really well. Nobody got paid. There wasn't anybody kind of saying, this is your job description. We just did it. And I thought, and I wrote an article about it, actually. But we've got the opposite, haven't we? We've got that you can't do anything without asking permission and someone blessing. And we need to loosen that up. We need to loosen it up. Otherwise, we won't be able to innovate.